All right, my friends, we are live on YouTube. We are live on Twitch, Facebook, LinkedIn, and Instagram. So, welcome to the One Moment Podcast, brought to you by myself, which is Kevin, Mr. Ruben, and Mr. Trevor. We are a mental health awareness, substance use awareness, suicide awareness, and basically a wellness podcast talking about a lot of different topics, whether it be loneliness, medication-assisted treatment, substance use disorders, anything related to basically mental, any topic that you could think of. Basically, we also discuss, ethics as it relates to healthcare, being a therapist. We also we're talking about clinical supervision. There's a lot of things we can talk about. So this is episode 2. We're going to get into that momentarily. I wanted to first start off with go over a couple of our sponsors. Can you pass me that, please? Our first sponsor, all right, is W Energy. All right. Any any type of products you get from there, use One Moment, you get 10% off all their products. Okay. That's going to be our first sponsor. We support them. They don't use artificial flavors. And they have use neurofactor ingredients. So the second sponsor of ours, and we're going to be updating the website with this once we get all the all of our stuff, the website's done. It's a place to heal, located in Sanford, North Carolina. This is where we are live from, and of course the state of Colorado with Mr. Trevor. So if you are living in Sanford and you are looking for mental health or substance use treatment, you can call a place to heal. They have a location in Sanford, North Carolina. They also have a location in Laurinburg, North Carolina. The phone number for them is 803-306-2458. All right. Again, place to heal. It's 803-306-2458. Now, with that being said, I'm going to let my colleagues introduce themselves, starting with Mr. Ruben.
So my name is Ruben Burney. I've been in the field over 25 years. I got my start in the field probably in the mid-1990s while living in New York. I did a lot of my internship to become a certified alcohol and drug counselor in the New York area. Worked at various hospitals, like in the detox unit, the medication-assisted treatment program there, the outpatient unit, and had the opportunity to also work with my wife in the behavioral care unit doing psychoeducation groups. Like I said, I've been in the field like 25 plus years, and I'm 68, be 69 soon, and I hope to be working till my 80s. At some point where I work at now in Pinehurst, imagine at one point they'll tell me one day, Ruben, you're too old, you're antiquated, you're a dinosaur, it's time to move on. And I say, at that day, I'll probably just clean the parking lot or do something, but I really enjoy working in this field. I really enjoy it. I would say, to make it short, I also have the opportunity, got certified in different areas, and I provide DWI assessment and services for the state of North Carolina. You can contact me, with that. I also do am a substance abuse professional for Department of Transportation, and I'm registered with the clearinghouse, the Federal Motor Carriers uh, Associate Clearinghouse. Well, anyway, I'm registered with them, so we call a SAP, but we provide services for the DOT. So just get in touch with me. That's it. My phone number is, I'm sorry, 910-54. Yes. And I have business cards and all that.
And where are you located?
And I'm located in Pinehurst, North Carolina. Let me give you, I have a business card. Sorry.
Business card. Oh,
What happened to it?
what I'm gonna do?
Well, I don't see it right now, but
Got to do it.
oh, here's my, can you see it? My business card. It's Live and Thrive, and it's the phone number. What that other number I gave you was my cell, but the phone number is 910-621-7176. And also my email address is liveandthrive100@gmail.com. Thank you.
Thank you, Mr. Rubin, for the
That was a long introduction, right?
glad that you're here and part of this. And I'd like to hear of the Live and Thrive activities
Yeah.
you're being a proponent of. And so now we're going to get to me. My name is Trevor Zylstra. In the sense, learning help.
What's happening with him?
That is a very strong wording in the meager sense that I'm actually doing things, but in this platform of us getting together and beginning this work, very privileged with the community that I'm providing working with you, man, so that we can help other people not only help themselves, but to help others so that we can spread this real information so that people have a real mental tool to use to get through. Ever. And we will not stop. I'm thankful for being.
Thank you, Mr. Trevor. I think you were breaking up during that, so let's just kind of monitor that and see what we need to do. Sometimes I know that if we turn the cameras off, then that'll usually help with the video, but we'll monitor it as we go forward. So, no, just for reintroduction period purposes, my name is Kevin. I am a licensed mental health counselor in North Carolina. I am also a licensed clinical addiction specialist in North Carolina. I'm also a certified clinical supervisor in North Carolina through the Substance Use Board. I know I've been practicing since January 2019. It started off in the field under Mr. Rubin, and he taught me a lot clinically. He taught me, just a lot of things. I think one of my strengths in the field is group therapy and understanding group theory. And I credit that to Mr. Burney. He's absolutely an amazing clinician. And Mr. Trevor, I've been on him for about, 4 months now, maybe 5, something like that, Trev. So gotten to know him. He's really a great guy. So we all decided to partner together and, do a podcast, a mental health substance use podcast, or substance use awareness, kind of like a wellness podcast for everybody. So, yeah. And that's the purpose of what we're here. And I know yesterday we were talking about, a lot of the directions of what we want to do with this. And I don't know, I know one of the things that we were talking about was medication assisted treatment for opioid use disorder. I think there's I think that's a topic that is least understood, or is not as understood as what it should be, what it could be. I think there's a lot of stigma around it. It is something that I think we need to talk about more, both in the medical field and the mental health field. Ruben, why don't you tell us a little bit about medication assisted treatment?
Well, I've worked in medication assisted programs for a significant portion of my career. Like I said, in New York, once upon a time, they called the methadone program. They would say you work the methadone program, but I've said that has changed. It's considered medication assisted treatment programs because of where I work now. That we provide Subutex, methadone, and Suboxone. Subutex and Suboxone falls, and all those other they fall under buprenorphine, and those are agonist medications that block the euphoria, the craving, that activate the opioid receptors, and helps the person to like get on a stable dose. First of all, when we first have a person comes in, where I work is very comprehensive. They start off with getting a person that comes in and they do an intake and what have you, and they go through the intake and see the nurses and the doctors and all like that. But basically, it allows that person, once they initially get on an induction phase, they get on a stable medication at that point and not experiencing withdrawal. And then they can start focusing on the other comprehensive services in the program. And that's what most medication-assisted programs, getting stable on the medication and helping with the withdrawal symptoms so they can focus on counseling and what have you. Kevin was saying there's a stigma, and I've worked in the field of addiction, over 25 years, as I said earlier, and I worked at outpatient in different programs, and there is sort of a stigma. Sometimes people think that you're just trading one drug for another, and I'm fortunate to work, and I still work in a medication-assisted program, and I see the progress that's been made with people who are taking these medications. For opioid use disorder, medication-assisted treatment and the various medications is the standard of care. It's considered. They found that, I can't quote the stats, but people who are opioid use disorder, who just basically engage in abstinence-based programs, unfortunately, they do relapse within a certain amount of time. And relapse is very, in whatever modality you work in. But they found that with these medications, the person they get medical care, some programs. They're not exposed to maybe HIV, hepatitis, different illnesses related to opioid use disorder. They can function, maintain a job. A lot of our patients, they come into the program for years and they do well. I liken it to, I remember going to a conference in Greensboro, North Carolina, and it was addiction specialist, physician. And he was saying that if a patient came in his office, he would never tell them to get off their diabetes medication like insulin or what have you. So he said, why would you strongly encourage a patient to get off their medication if they're on a maintenance program? And I think it's basically, it's a definitely good modality to work in. I enjoy working in it.
So, may I please show a video before you talk, Trev, if you don't mind? I want to show a video for our audience because I think it's critical because we are talking about, opioid use disorder and medication-assisted treatment. I would like to, if y'all are okay with it, show a quick video to the audience on this and let me know if y'all can hear it, okay, on, as far as, YouTube. And then after the video, Trev, then, say whatever you got to say.
Okay.
So for the audience purposes, this is Jelly Roll testifying in Congress on the fentanyl epidemic and the fentanyl bill. And it's not so much the politics behind it, okay, that I want to stress, but I think it's the information, right, to the public that I think is even more critical, right? So I'm going to go ahead and play it. And then after that, Trev. So I wanted to share that because I think it's important to think about the impact of substance use, not just fentanyl, right? But that statistic is 100 and what do you say, 190 something people,
Yes.
the size of a 747 Boeing jet die every single day from an overdose, from a fentanyl overdose, right? That's huge. So thank you for sharing and telling us a little bit about medication assisted treatment. Mr. Trev?
Yes. I think I have to be kind of partial to the Mr. Deli Roll quite a bit because the addiction part of it is got a lot to do with mental state, the mental state of mind that you're in. Um, wow, I kind of balked a little bit about paying any attention to somebody like that, but I never heard that video or saw that video. But it me that he's very adamant about trying to get something done about this. Now, with the research that I did myself within the past 6 hours, I found that in 2022, and this is a statistic, but in 2022, there were approximately 885,000 people in their data that they presented that had died at that particular time from fentanyl, and that was 3 years ago. I know that Mr. Jelly Roll did this fentanyl promotion thing within the last 6 months.
I think it was about 2 years ago or so, 3 years ago. I forget. Yeah, but it was a few years ago. But go ahead.
I don't know. Well, I stand corrected on that, but that's okay. It shows that this whole fentanyl thing, it's terrible. It doesn't matter if you're in an institution by your choice or not, that this thing. So my experience with it is in the size of two crystals of a salt shaker can kill you. It is not a joke. This whole state of thinking that a chemical that is supposed to be, I don't even know what it was created for, but it's a bad deal. The only thing you're really doing is signing your own death warrant. And that's a consistent thing. So, boy, the the things that are being done to help the treatment of people that are going through opiate use disorders or any other disorders, especially with this fentanyl thing. I mean, people that don't know how to handle it can be affected by it. And that's a very dangerous thing. And it's very critical that you pay attention to what's going on around you and what you're involving yourself with, because this can kill you. It's not, it's serious. And that's why I grouped with the Jelly Roll about uh, help in any form or fashion. That's a good start on our discussion. And that I liked how Mr. Rubin had stated that the the medications for opioid users with the opioid use disorder trades one addiction for another. That's a myth. That's a terrible stigma. Like, to think that someone is exchanging their addiction to an opiate for another addiction. The process of getting to the point where it could be used as something to helps them get off from the substance that's killing them. So we kept it as the proper procedure because it's a productive thing to help someone in their own life. And that's what our whole goal is, to help.
Yeah, no, I think you're you know, and I appreciate you sharing that. There's a lot of stigma as far as like medication assisted treatment and just to as I want to touch back on what you said, and then Ruben, if whatever you got to say. But this right here, folks, is an actual true size penny, right? Like this is a true life size photo, right? And this photo is posted by the University of California, San Francisco School of Pharmacy. So this isn't, anything that, I am making up, right? Like this is stuff that, we're taught in the healthcare profession. Is this little bit right here, this little bit of fentanyl right here, right, is a lethal dose for most people. And you see it right there. 2 milligrams of fentanyl. That's 2 milligrams, folks. And so, I think what Mr. Trev was saying is, I think it's important to talk about, fentanyl, opioid use disorders, medication assisted treatment. And it doesn't matter if we call it a brain disease, existential disease, it doesn't really matter. Uh, you know, because not one approach fixes everything, right? Like it takes a school of us, right? It
Mm-hmm.
takes a village to
Mm-hmm.
help out in the field. And that's just my thoughts on it. But yeah, thank you for sharing that, Rev. I think this is something that the general public doesn't really talk about.
No,
And if they do, then hey, listen, my hat's off to you, and let's keep the conversation going.
right. Now, just looking at the picture from the training that I was provided, and I understand through the profession that I was involved with, that is enough for about that can kill 20 people. Because I'm talking even the little grain of those is detrimental. It can put somebody that's never been exposed to something like that in a life or death situation instantly. And it's terrible that people think, whether they're in or out, wherever they are, it will kill you. So it's very important that people realize that this is not no joke. It is not any joke at all. It is a life or death situation. And when you decide to try to use whatever substance like that for kind of a relief of the stress that you're under, that is extremely terrible. And it's very concerning, especially if you're trying to hide it from someone. And even if you do it out in the wide open, that's even worse because you can kill other people and not even know it. It's a terrible, terrible, terrible thing to have as in our amongst us. My professional experience.
Can you hear me?
Yeah.
One of the things I find, I talked about the stigma with like medication assisted programs, but unfortunately and I think it's changed. There's a stigma with addiction, period. Years ago and there's different models, like talking about the brain, the disease model. Years ago, there was a model called the moral model, and it was about, well, the person who's using drugs, they have low character, they're considered immoral, that they have lost favor with God and all those different things, and that make a person feel like, just having that disease. So I always say there's a stigma with addiction just in general, not just with medication assisted treatment. But the good news is I think it's changing. I've been at the program where I'm working for like 13 years. Like I said, I'm originally from North Carolina, but I lived in New York for like 40 years, but I'm originally from North Carolina. And I work at a facility right now that we getting a lot of, the hospital is right across the street. And we get a lot of referrals from medical professionals, for people who come in with fentanyl. And the belief when I first started there, I was told that they didn't have a good relationship with the hospital because of the stigma. But I find that's changing drastically. I mean, we get a lot of referrals from the hospital because people recognize again that for opioid use disorder, medication assisted treatment is the gold standard or standard of care. I see it where I work. It doesn't discriminate. There's generations like grandparents, parents, grandchildren, children. That's all I see in our program that So I say definitely doesn't discriminate. So the hope is that it is changing. I'm not talking about the stigma, but it definitely is changing. I think, like Jelly Rose said, somebody knows somebody in their family or relative or whatever that's been affected or impacted. So I think that is changing. People are more accepting of how they treat an addiction now as opposed to 20 years or 30 years ago.
Yeah, no, I think you're right. Even I even got to talk for myself, right? Like, I have, I know personal, know people personally, that are close to me who, years ago they were telling me about it, and I didn't, I was completely against it because of my own personal biases, right? I'm like, man, that's just another drug, that's substituting one drug for another, like you and Trev were saying, right? And so, uh, I mean, what and it's funny because that was my biases, right? Those were my biases. But my first job was at a medication assisted treatment program down in Pinehurst. And I don't know, like I had gone through I had did an assignment or some research on MAT, and that kind of challenged my biases. And then I started working in MAT, right? And MAT is short for medication assisted treatment. That's the abbreviation we use in the field. So, long story short, uh, as a result of starting in the field and working in the field, I've been able to actually learn and grow, and understand MAT and the principles of MAT. Now, is it perfect? Absolutely not. MAT is not perfect, uh, and I think COVID, the COVID era, really showed us that. It showed a lot, as far as a lot of systemic problems, or systematic problems, um, because there was a huge focus on substance use, especially opioid use disorder treatment. And one of the problems I think, and this is again a personal, but I think if we look at go back in time and look at all of the media, or the news networks, uh, there's a there's a there was a huge infrastructural problem with access to treatment, right? And being able to provide adequate qualitative treatment. And even to this day, I still think that there's a, uh, a huge infrastructural problem. And there's many issues, that go into why the infrastructure is not there or is lacking. Um,
Down that another stigma that is really inherent in things is that there are multiple comorbidities that can make physicians and patients feel uncomfortable with the idea that somebody is having to have another medication for their treatment. But instead of that goes to me on the bottom of this thing that you're sharing with us. The very last line of it is very important because it says the moral model, or whatever a person's feeling of morality is no longer considered therapeutic because it is being as harmful. And that was something that took place uh, in the 1800s. And here we are 100, 240 years later, still dealing with same moral ideals that were instilled into us in the human existence at that time. No, it's very important that we deal with things on now terms. But so many people they've got these ideations of their moral uh, perspective is better than everyone else's, and no matter what you do, you just have to abstain from this and let this higher power and that thing be the reason why you stop this. But some people cannot. That's the development of this. That extrapolates the moral model of addiction completely. Their very last line that I see there, and I wrote that down. The moral model is no longer considered therapeutically valuable and is increasingly recognized as harmful. So, because you think something is wrong because your morals are better than someone else's, that doesn't give you the right to disregard the medical that is being prescribed for these people that are dealing with opioid usage disorder, which is one of the many brain disease, a minimum of 32 nervous system disorders or a brain disease. There's many more that included, but there's many listed from the source that I got the information in, and they require clinical care by a physician or another healthcare professional, whether that be mental health or physical health, psychological health, psychosocial health. There's so many things that envelop this idea of medication being used to help these people recover their lives so that they can be functionable in a positive manner.
No, no, and I think that's the importance of understanding MAT, right? Because they prescribe method depending on the agency. Not some agencies might differ in the medications that they use, right? And so definitely, if you are seeking assistance for MAT, right, like find out like what kind of medications they use, or they prescribe. Some clinics do the pill form of buprenorphine or Subutex. Some clinics will give you a prescription for Suboxone, right? And then you have, of course, the other widely used medication, which is methadone, as Mr. Rubin was sharing earlier. And so all of those medications, as Rubin shared, was is considered to be the gold standard for the treatment of opioid use disorders. And then and so I think it's important to understand, like, or at least to talk about. Yes, I'm glad we spoke about the moral model of addiction, right? Uh, and so, and you mentioned many other things, Trev, as you were, talking, psychological factors, brain, all of that stuff. And so, that brings us into more contemporary, models of addiction, right? On like how come people do become addicted, or how come people do use. And so I'm not a huge fan of the brain disease model of addiction, but I know Mr. Rubin is. And so go ahead, Rubin. Why don't you go ahead and take the floor?
I don't see the camera, but that doesn't matter. Yeah, I'm a uh, component, a significant, believe in the brain disease model. I think it's not one size fits all. You have to. When I see a patient, I even with therapy, we use different types of approaches. It's not one approach fits all. So, or one size fits all. So, we talk about motivational interviewing, cognitive behavior therapists, and just the same. I was reading about. It's hard to pronounce that word. Existential model, and I agree with some of those concepts that are in that talks about that. And with the brain disease model, I mean, a lot of that, I had the opportunity to, there's a company that's called Prime Research Institute, and they put out a curriculum, and it's revised, a new revision comes out every few years. They've been in existence since 1980. And SAMHSA approves this curriculum, and it's used for underage drinking programs. In North Carolina, they use the standard for DWI programs, or what they call ADACs. It's used for court programs, and the curriculum talks about the disease model, and it talks about. And one thing, when I teach this curriculum to DWI individuals who got a DWI, one of the things it talks about and it stresses is biology plus choices equal outcome. And what they talk about is every one of us has a trigger point where we can, and addiction doesn't happen overnight. It's a gradual process, but we all have a trigger point where we can reach that point where we now in the phase of addiction. Uh, but what things we can change is our biology. Just like if I have a family history of heart disease, there's a component of that biology I can't change. Uh, but the other factor is choices. They talk about when a person has diabetes, for example, that person not only takes insulin or other type of medication, I forgot the name of it, but they also have to make lifestyle changes. They talk about in the most developed countries, one of the biggest causes of death is lifestyle related diseases, meaning that uh, the person not being able to or not managing those diseases like diabetes, which might result in kidney failure, so there's a lot of factors that come into play in our choices. A lot of those are psychological, social. Uh, it talks about years ago, for 20, 30 years ago, if you were into health, you were considered a health nut. But now it's popular to go to gyms and what have you. But if I'm prone to heart disease, if it's in my family, and then I work late, say like I go to work at 6 in the morning, I work to 8 at night, I stop at McDonald's to get a hamburger. I don't exercise. I think exercise is ridiculous. I hang out with people who maybe we're gonna have a drink constantly. I become social dependent, and that's my social circle. Then those are all the things that affect choices, and that's what uh they talk about in Prime for Life in this curriculum. They acknowledge that it's not only just the brain, but there's other factors that come into play. One, social environment, the attitudes. Uh, I talk about generational, like for us in the clinic I'm at, uh, because a lot of those attitudes are handed down from generation to generation about drugs. And so breaking that cycle. So I think it's important. Again, I don't adhere to one moral, but I definitely know the moral model is just antiquated. Like Nancy Reagan had this thing back in the 80s, I believe, just say no, and we know that doesn't work. People wonder, why
I
can't
know,
people
right?
stop who use drugs? But there are brain changes that occur uh, that have that impact that changes the person. People talk about, well, I was born for addictive personality. That's what people often say. But research shows that uh, no matter what type of personality you have, you can develop addiction over time. One of the things with the person with that is no matter what people say addictive personality, we know that once a person becomes addicted to drugs, there are changes that occur within their personality, uh, their defense mechanism they develop. Uh, I don't want to hang out with people who are not like me. So uh, those those traits, those what they call maladaptive, unhealthy behaviors are reinforced. If I'm in a social circle and I say, well, you know what, all my friends drinking do drugs, and I might think that because I'm in that social environment and I gravitate towards that. So there's a lot of brain changes that occur, but I don't say that's just one model and that's the only one that works. Definitely not.
Well, I'm glad you mentioned that because I'm not a huge fan of it. My you know, what I went through, and Mr. Trevor might have or Mr. Trev. Let me get back to his nickname, right? Trev. Trev might have a different thought process than myself. I don't know. And he might agree with you. It doesn't matter. I mean, there's no it's neither here nor there. Well, from my experience, when I was trained in the brain disease model of addiction, um, and this also part of this goes back to stigma too. So I'm glad that we're talking about this. Uh, there's a big push about dopamine, right? And dopamine is the one neurotransmitter for the whole brain disease, right? Model of addiction. And at least that's the way it has come down the drain pipe, in many textbooks and many classrooms. Now with that being said, dopamine is not the only neurotransmitter, in the human body, right? It's not. And then another reason why I disagree with the brain disease model of addiction is just because, again, do I think it fits? I think it fits for certain people, as you said, Ruben. Uh, but I think there's many other folks that the brain disease model doesn't fit, right? And so another reason I don't like the brain disease model of addiction, um, is because I'm a huge proponent of existentialism, um, uh, and not just existentialism, but I think it's more so of taking a biopsychosocial approach, and being able to talk about, um, y- many different aspects that the patients, might be able to grasp, right? And then if, what, according to research, and I know we were all three looking at research of many different pieces of the research for the last week. We've all been throwing out ideas and concepts and kind of talking about it, right? But part of that research even shows that, for treatment centers that go strictly off of a brain disease model of addiction, that's a stigma because, what about those who don't believe in in the brain disease model, right? What about those patients who don't believe in the or brain disease model of addiction? Well, where they're supposed to seek treatment at, you know, and so I think it really disincentivizes individuals from seeking treatment, uh, for their substance use concerns or their substance use disorders. And that's just, my thoughts on that. And so with the biopsychosocial approach, we talk about the physiological changes, the neurological changes, but we also talking about the spiritual changes, right? We're talking about the social changes, as you shared, and as Trev was sharing earlier. A lot of the psychological and social changes, but both of you hit on a lot of it. And so I think it's, for me, I'm gonna just what I have found to be helpful is looking at trying to get down to the root of how come they use, right?
Hmm. Right.
That could be an existential problem. It could be a spiritual concern, right? I know the 12-step programs hit on a lot of those, different factors. Um, existentialism is a big piece of it. This is what I really, appreciate the existential model of addiction. And when I actually studied it and started studying it and started becoming, teaching myself about it and learning about it, it really clicked. A lot of that stuff really clicked on the biopsychosocial model of the approach that we take, right? When we're working with people. Trev, I wanted to hear from you. I haven't heard from you in like 30 minutes because, Ruben likes to talk a whole bunch. So I want to hear from you now.
Going over my stages here, and one of the biggest things that I have to verbal and get out there is that there's a statement in some of the research that I did that says phenomenological and existential research support the fact, not the other, and both of them support the fact that existential issues are relevant to addiction of all kinds, sorts, forms, no matter what kind of it. And the reason why some of those are substantiated in someone's life, or they insert that into their lifestyle or their kind of thinking, is because it's a coping mechanism for them, to deal with anxiety. And that's either existential anxiety or neurotic. For neurotic, automatically you're thinking brain. But it's critical when whatever kind of addiction you're addicted to, there's a problem, and it's dealing with the human brain. There can be situations, a death or life situation, personal freedom situation, whether it's legal or situational, uh, of your personal freedom being at risk. Uh, People isolating themselves just so that they can exist being by themselves. There's a lot of people that do that. They want to be alone and not be around other people uh, so that they can, separate themselves from others for a reason so they can gain their state of mentally being. You might have a feeling of meaningless. What are you? What's your existence meaning? Are you guilty of something? Do you have a problem with control over something? Which could be boundaries. Is another secondary type of suffering that's there. So when it says phenomenological and existential research support the fact that its existential issues are related to relevant to addiction of all types, kinds, sorts, and forms of addiction. It doesn't matter what. I get the idea that there's so much stigma or myths related around because people believe a certain way or they think a certain way that this is bad because of this. No, it doesn't. The addiction part of it affects every person of every professional or non-professional uh, stage of life. Unfortunately, I just read a statistic about back in 2022, approximately 75,000 adolescents were killed from fentanyl.
Wow. Hold on. Can you, just to make sure I heard you correctly, what was that number again?
75,000 adolescents to 12. And that was back in 2022. So that's extremely disturbing. It, I mean,
1,000 adolescents.
that's in,
That is,
that's in 1 year back in 2022 from when this data was collected. And that blew my mind. That's on top of the adults 12 years of age or the people 12 years of age and older with 882,000.
so sad.
Why is there not as much of effort being projected to how like disastrous relation that this fentanyl thing really is? I get it with what Jelly Roll was saying. This fentanyl thing is a big deal. It's not going away anytime soon, especially when other foreign countries produce it and get it sent here somehow.
No, and yeah, a lot of that I think, and Ruben, you might or might not agree. I've worked in M18. I've worked at a few different places, and hey, one of the big problems, and this is why I am not in addiction, like specifically in working specifically in addiction therapy, right? I mean, I still do addiction therapy at my current job, but it's more kind of but I work at a local hospital on the inpatient unit. And so one of the things that, well, when I if we go back to the infrastructure, right, in the substance use field, um I can get a job as a mental health therapist under my mental health license, making, you know, uh, anywhere from 80 to, six figures a year, right? Uh, or at least close to, I mean, I don't make 80 today, and that's just because of me working at a hospital. And of course, I think what I make is decent. I'm not going to, I don't have any complaints over what I make. Um, Mm. But when we look at addiction therapy, right, in the MAT clinic, uh, I got to tell you this. I was mentoring a guy, And he's a great dude. He was a great dude. I mentored him in his last year of college because that's what I do. I mentor students in their last year of their grad school, when they're going through their internship and practicum. And this guy, know the folks he worked at, the place he worked at, so I can't say any names, and of course I have to protect confidentiality. But the experience, I think, speaks volumes for the addiction field, right? He was going from his CAD-C to his license in addiction therapy. And, part of the issue, like I say, the infrastructural issue is the fact that, uh, you know, they told him, say, whenever you get your license, we're going to give you average pay, right? We're going to give you a pay raise and it'll be average. And so they told him, and that was $20 an hour, $20 and like 15 cents an hour or something like that, right? And so, and in part of my supervision and mentoring, when I provide those types of services to the individuals I serve, uh, I always talk about self-application because self-application is critical. It's important. And so I asked him, I said, dude, I said, because he asked me my thoughts. And, when I'm put in that type of position, I'm going to just be honest with folks, right? And so I asked him, I said, listen, I said, if you're asking me my thoughts, are you sure you want to hear it? And he said, yeah, sure, please go ahead. I want to know if that's something I should accept or not. And I said, well, if I were in your position, I would ask them, is that local pay, right? Is that based on local numbers? Is that based on uh, average state numbers? Or is that based in national numbers, right? Uh, and that's true, right? That is true. Uh, and I told him, I said, dude, I said, there's so many. I said, listen to me, boss man. I said, there's so many jobs out there that will pay you significantly more once you get your mental health license. I said, that's the problem with substance use therapy, and that's why I don't work in it. Right. And so I'm gonna use that, right? Like they didn't offer him anything else. From my understanding, they didn't offer him, they didn't renegotiate it. But and at the same time, there was another situation with another person that I was mentoring and or supervising. Um and they were going for a position and they wanted my thoughts on, how to, do the interview. And I, that person and I talked a lot about the interviews, the process, and they said, well, Kev, I would like to make this much money a year. And I said, okay, cool. We'll just ask them. And so they offered her significantly below that level of money, right? Where she was asking. And so she told me what they offered her. And I said, well, listen, I said, can you make it on that? She said, no, I can't. Kev, I said, all right, cool. I said, well, hit them back. I say, lay out the reasons why you should get paid this amount of money that you are requesting. And she did. And they, about a day or two later, she called me up. She was like, Kev, they offered me, it was like 2,000 less, maybe 3,000 less of, what she was offering, or what she was requesting. Right. And, long story short, she and I spoke about it. And I said, well, listen, they gave you some great stuff. They gave you great feedback, great information. But my question still is the same. Can you make it at that much temporarily or whatever? And she was like, yeah, Kev, I can do that. She was like, it'll be a tight, but I can do it. I said, all right, cool. I said, take it then. That's something you can do. Take it. And she took it. And here's the miracle of it, right? Because I teach application, right? To everybody I mentor, supervise, all of that. Like, I don't even care. I teach it because it's important. Self-application is critical. I could speak all day for somebody, but
Oh God.
that's not going to be as important as somebody else, right? So long story short, she hit me back about 30 days later or so, 45 days later. She said, Kev, I got some amazing news to tell you. I said, what's that? She said they called her back in the office. This is 30, 45 days into her employment, and they offered her uh, what she originally asked for. And so that's a problem in the that's one of the problems in the field as far as it being related to the infrastructure of why it's hard to treat substance use when you have
because of the
lack of
pay.
yeah, pay is a huge problem with substance within the substance use field.
I don't think nobody goes in this field thinking they're gonna become make 200,000 a year. But for
I don't
example,
think it's
wait, let me finish. But like for example, I worked in New York area, and because of cost of living and everything, I made substantially more in New York than as a counsel than when I moved back here. But the cost of living, I had to accept that. You know what? The cost of living, houses, taxes are more. So I was older too. If I was younger, it might have been different. But I was ready to move back to North Carolina, and they offered, we they gave we discussed it, and I was prepared. And I think I never said to an employer, "This is what I deserve." I always said, "This is what I earned." I think you have to advocate for yourself. And yes, after you I tell my grandkids, you're not gonna come out of college because you come out of college doesn't guarantee you're gonna make this substantial salary. But I think as you get experience in the field, people value that. You have a license, I have a certification. I don't minimize that. But like in the New York area, and when I moved here, I never had falls placement of finding a job. I chose to work where I at now. And probably if I left there, I'm sure I probably could make more money somewhere else. But I like what I'm older. Money isn't a driving factor. I'm no means rich, but I'm comfortable. So I said that I work where I work now because number one, I like it. Uh, they give me the opportunity to do things on my own. Like once the building closes, for example, DWI, uh, substance abuse assessments for the Department of Motor Vehicle, North Carolina. Uh, substance abuse professionals for the DOT. Those are things that they allow me to do on my own. So I like that, but I always say you have to advocate. And maybe when you come out of school, you don't have that experience, you can't. But yeah, I'm a big component of you need to advocate. Uh, sure, definitely, because some people will uh pay you less than what you're worth, and you have to. Sometimes unfortunately, you have to move on, like probably like you did. Uh, but yeah, I'm a big. I think with a certification, I found avenues to make more money. I didn't know that. Like when I moved to North Carolina, that you could do substance abuse assessments for the DOT with a certification. That you could work for the DOT. You could a lot of things I could do that I probably couldn't do in New York. But so I don't think people get in this field for just for the money per se, But yeah, I think different places pay different as well. I know friends of mine who moved on. They work at other places out of in North Carolina that pay very well. I'm aware of that. Sure. I always say pay me not what I never come to employ what I deserve. What what I believe I earn, what I do for the clinic. And you can do that after you have experience. You definitely.
uh, Trev?
Um, I'm just kind of casted by the amount of different throughout. Pardon me. Just amazed at so many um, can amplify someone's reason to beginning to use any particular substance to an extent that is going to require their uh, medically treatment, and then other people are going to say to them, "Well, their treatment is disturbing to me because they could be addicted to it," or as there's so many overwhelming confluences involving. So uh, it's a little brain. I'm not person, or that's not any worse, but what I've been finding is that talk as discussion about work and being mental health professional, behavioral, um, you're in a medical environment, you're a little bit more safe. There's other people that are uh, behind certain institutions that are developed for people that are dealing with the criminal end of their substance use. Those people are getting tremendously rewarded for their service in that area. Um, and it's even more disturbing, especially when there's substances that are uh, involved in those environments that can kill people. That makes me even concerned because I was one of those people that did that work. And so those people's lives are critically in risk, and they are the ones that should be paid more instead of just the person that, you're setting behind in a safe area. Then that's just my perspective because I was involved in that group of people.
Mhm.
And more than law enforcement, it is a division of law enforcement, but it is the unrecognized division of law enforcement. They put themselves in the environment that even lots of criminals are scared of. So I don't know. It's just so overwhelming with all these addictions, and medical treatments to them are perceived as being a problem. There's a moral issue which also extends into the neurological sense of all this. So there's so many factors and so many things that we have to consider throughout professions and careers and all these things. But if we're in the member of the human uh, group, which is all of us, we should strive to help others, whether we're getting a giant pay cut. I it, it's kind of overwhelming. This topic is maybe overwhelming me a little bit. It's stressing me because there's not enough. It seems like there's just not enough people that care anymore, and that's it doesn't mean that we have to go by their standard of caring, but humanity and people must care about others to help them instead of just saying, well, this type of program doesn't work. We can't accept that because those people are dangerous or their conditions are terrible. They can't be of some use to us anymore. And that's something that I've personally experienced where being just thrown away from part of society is a detrimental thing to a type of addiction, no matter what kind of addiction it is. So,
I'm glad we get we cover a lot of topics, and sometimes we have an agenda, but I think when it's organic and you just have discussion, and hopefully that draw other people into the discussion. But one thing you were saying about, I know some prior to getting the job I'm at now, I had an opportunity to interview with the program in Goldsboro called a Dark Cherry program, and I did a conference call, and they were interested, but I didn't end up taking the job. But one of the things you talk about is being a counselor, like in a prison environment, those environments. But I find that, and it is more risk, but I also find, like, just in general, when I do an intake and a person sits across from me and tells me, when I ask them their legal history, and they look at me like they're ashamed, I'm like, and somebody might say, well, I was in prison for manslaughter. I don't go, oh my God, I'm scared. I understand I'm in the wrong field of that. Yes, I value safety, and we talk about that. But I've been a counselor for 25 years. I've never been threatened or felt. So far, it's because I try to treat people with dignity and respect. And even, I always say, even when we sometimes have to involuntarily, a person who maybe has threatened a staff member or something, we have to uh, administratively take them off methadone or whatever, and I don't use and put them out of the program. Even that process, I try to be nice about that. I'm like, you know what, maybe this type of treatment isn't working for you, but I always say, you know what, just in general, you come into this field and it's about caring. I I really enjoy the field. My wife often asks me when you're going to retire, but I say, you know what? I can see myself working to 80, maybe not 5 days a week, but maybe
Right.
3 days a week, and eventually running my own DWI business and all that. Those are goals I would like to do. Sure. Yeah.
No, and I think I love really and truly what both of you shared. And the first thing that comes to my mind, that or came to my mind as you two were talking was the humanistic theory, or the humanistic principles, right? And I don't mean like humanistic theory of psychology or no, humanism, just simple humanism. And this will be a topic for another episode, right? And hey, shoot, we ought to be able to continue this conversation on episode 3, because man, I know we came in here with with an agenda, but we have really talked about the infrastructure. Oh gosh, this has been so organic, and I love it. And Trevor, Trev, I'm not gonna call you Trevor anymore, brother. I'm just
Trev.
saying, sorry, Trev,
Yeah.
right? People call me Kev and Ko or Kevo, so I'm gonna call you Trev. All right,
What do you call me on the phone sometimes?
shut it. So, so, but I think it's the simple principle of being human, right? We are naturally wired to you know help one another, and whether you don't like your job because you get paid, because you don't get paid well, or because you like your job you get paid well, either way, right? We all work in we're all in some type of form or fashion or way in the field of healthcare, right? Even doing this podcast, yeah, we're still doing healthcare. And so, I know we got to wrap it up. So, um, since we spoke heavily on uh opioid use disorder and medication assisted treatment, I would like to, would it be okay with everybody if we talk about, where to seek help from? I can pull up the site. I can share it with y'all. I can share it with the audience and the public.
Okay.
Sure.
Okay. So this is what we call
That's
the
pretty much
directory.
our main goal.
Yeah. Can you say that again, please?
I was just saying that's pretty much our main goal, is to give people the resources that they need if they're having a trouble or issue. And it doesn't matter what level of professional, non-professional sort of life at, because it can affect anyone, anywhere.
Yeah. No, you're right. So anybody can go to any website, and y'all can see that I use Brave browser. I like it. It's Web3 technology, but we're not going to go into that part yet. But I just Googled or Brave, to search to whatever directory of opioid treatment programs. Now, since Trev is in Colorado, uh, um, we're going to go there first. So whenever you go to this page, and this again, if you're looking for opioid use or opioid treatment, also known as OTPs or opioid treatment programs for opioid use disorder, also again interchangeably medication assisted treatment. Uh, this comes up, right? And then you can select which state that you are in, and I'm gonna pull it up, and I'm gonna let Mr. Trevor talk about some of these, not specifically the programs, but let's, Mr. Trev, if you
that
want to go ahead and
Colorado?
start naming out some of these cities in Colorado for our audience.
Okay. Oh man. Okay. We got, and there it is. One in Alamosa, but Crossroads is a statewide program, whether you're in Denver, um, Pueblo, Colorado Springs. I don't know if they're anywhere in Grand Junction or not, but I mean, the state is covered through the Crossroads program. There's places in Arvada, Aurora, Boulder, Brighton, Centennial, Springs, Denver, a bunch of places in Denver. I'm certain of it. Englewood, Glenwood Springs, Fort Collins, Lakewood. I know there's another page because I've seen this list before. There's North Glen. There's Old Pueblo, and Westminster. So the state is covered. If you have any problem, trouble, or issue with any opioid usage disorders, there's treatment available out there for you to be able to take the first steps necessary to get the help you need. In Colorado Behavioral Association, Administration Association, it's either Association Administration or Administration Association, I'm not sure which, but the resources that they have provided for behavioral problems or troubles are available. If you want to go on the .gov website and click on their link, you can get resources from there too. I would highly encourage anyone to not just say I'm going to live with this for the rest of my life, because you're killing yourself, and I don't want anybody to hurt down like that. That's a bad way.
No,
Yeah.
and I do appreciate it.
I get a little bit emotional about it, but that's because I'm a human being who wants to live, and I want everybody else to live a good life as well. So,
It's amazing how you see different. Like when I use the OTP directory, in some states, like I see Colorado, they have 2 pages. New York probably has about 8 or 9 pages or even more. North Carolina, and then like West Virginia, I know we have the corporation I work for. They have a clinic in West Virginia, and some places really don't have a lot of treatment. Some people in rural areas have to travel miles and miles to get, treatment.
no, you are right, and that's why I was highlighting, and I think Trevor's I think Trev hit on it, and if he didn't, then I'm gonna pick it up. But we can go back, right? 44 OTPs in in Colorado, right? And then if we go back to North Carolina, it's 91 clinics across the state. Now here's the catch 22. Colorado is more rural than North Carolina, right? They have more people than North Carolina has. I think that's the way, or
Yeah.
we have more people than Colorado, or something. I forget. That's neither here nor there. I'm not a population expert here. But Ruben, go ahead and tell us about some of these clinics. Start naming us off some cities for our people who cannot see.
Well, if you go to OTP directory, you click on North Carolina, you'll see a lot of programs. I don't want to say the name of the place I work because I think I'm not allowed to, whatever. Don't want to get sued or
No,
anything
you
like
can.
that.
You can.
No, I don't want to do that. But I can say like,
So you can say the name of the place. But here's what I want, because I work at Novi, right?
Mhm.
I can say where I work at. I can't advertise. I can't wear like my shirt uniform and all of that.
Mhm.
But they know that we're going to be talking about like services in the community, right? And they understand, right? I can't share any type of inside functions of what happens on the inside of the hospital or anything like that. Um, so it's not about getting, when I use the phrase getting sued, I mean
I was
like, hey,
joking.
oh,
but you're
okay.
not. Remember, assume anything. Assuming makes an ASS out of you and me.
Yeah.
Remember that.
Yeah.
Just
I can only speak for where I work at though. Like
Mhm.
my job knows that we're going to be talking about services. So, but go
But in
ahead and
North
name off
Carolina,
some of
there's
the,
quite a few programs. I can see, there's a list like there's a high concentration of programs like in Fayetteville. I'm partial my hometown of Salisbury. I see there's a program. I think Rowan Treatment Center. There's different ones. If you Google, I mean, if you look to that, you'll see a lot of treatment programs in North Carolina and other states. So they can look at them, and see that there's a vast array of programs. And all these programs, the ones I've dealt with and refer people to, they come back. A lot of them do offer comprehensive treatment. We talk about the different models of addiction, which, I don't really get into that. I think the main thing is you want your program to have staff that cares and offer comprehensive services. And I think that's what's important. They always say the reasons why a person uses a drug or drink, I'm not saying it's irrelevant, but the thing is they use them. So you want to have services like where counseling comes in once in an opioid treatment program. Once they get on a stable dose, we want them to start looking at those, what they said, they'll dismantle those addictive behaviors that developed over the years. So I think, the different models, I mean, it's relevant in a sense, but I don't get into debate about which one is. I think a lot of programs I work, they integrate all those different models and to help the patient. It's basically patient centered. You know what I mean? But they
Yeah.
can look at a lot of
Carl
programs,
Rogers.
4Ps in North Carolina as well. Sure.
Yeah, no, Carl Rogers was the author of person-centered treatment,
Yes.
or person-centered theory, excuse me. Uh, and I am a huge proponent of the idea that if he were living today, he would probably be turning in his grave, or his head would explode just because of the how things have went from being patient-centered to not being patient-centered. Um, But again, that's a topic for another day on person-centered theory, because I mean that's one of my favorites. Um, so uh, any final thoughts on anything, fellas?
Trevor?
Oh boy. All right. I don't mean to get sidetracked or not or anything like that. Well, that this addiction thing is a nationwide, worldwide problem. We have to be active that if we are going to endure the knowledge of us being productive to be able to help other people and continue helping other people, we have to make sure we help them find the resources they need for the particular situation, whatever has driven them to the ignition that they're involved in, or the help. It's not something we do for them, but we can be active in giving them this opportunity to get the resources and use them for what they need.
Yes. Please seek help. Disclaimer. Nothing on this podcast that is shared on this podcast or on our website, once we get that finalized and up and running, is meant to be construed as or misconstrued as receiving any type of legal, clinical, or medical services. There are resources, as Trev was saying, and as we've been talking about, Mr. Rubin has spoken a lot as far as different resources too out there. We've all talked a lot as far as all the resources out there, but none of what we share or talk about uh, uh, or speak about should be construed or misconstrued as receiving any type of legal, clinical, medical services. If you need help, please seek it. You have the number to 911 if you are in a territory that uses 911. You also have a territory, you also have 988 if you are in the United States or a territory that uses 988. 988 is the National Mental Health and Suicide Crisis Hotline. Please seek it. Seek a help from a local emergency department. Seek help. Domestic violence hotline, sexual assault hotline, many different things. So please, Ruben, you want to close us out before I do the final before I do the final thing?
Well, I want to say I glad to have the opportunity when we come up with the idea of doing a podcast, and glad Trevor joined in. I'm elated, happy to do this. I say it's a learning experience for us. Like I hear people talking about Joe Rogan podcast and how many followers and all he has, and we thinking big that maybe one day we could be like that. But I just say if you reach one person, I think it's important that I'm excited about doing this podcast. Although I say I've been in the field 25 years, by no means do I say that I learn everything. I learn from my patients, my clients, the staff, from younger staff, counselors who start in the field. I never proclaimed that, I have 25 years experience. I know it all. I hope to learn from the audience. I hope they participate and give comments and let us know how we can improve this podcast. That's important. So I close on that note, Kevo.
Okay. All right, Rubio. So last and not least, I reached out to the owners of WebHash, got their permission to advertise on the podcast. Our website is a decentralized website created by the tools that are provided by WebHash. I'm trying to get permission to start advertising for 3DNS. We do support them. They do sell domains, decentralized domains. They take your domain and turn it into an NFT. I can't legally, or excuse me, we can't legally advertise for them. Okay. Just because I'm still waiting to get that final permission. I've already reached out to them. But I will support them verbally. Please, if you are into Web3 technologies, definitely check out WebHash and also check out 3DNS. And then we have the last, again, I think we're going to reiterate this. I saw Ruben pick it up, so I'm going to let Ruben close us out.
I wanted to say the place to heal in Sanford, and we gave them the phone number again. It's 803-306-2458. I just want to say that because I had the opportunity to work with this young lady when she worked at our facility, and I maintained contact with her. And when I called her, asked her, can we do a podcast here? Can she host it? I mean, without hesitation, she said yes. And she's been overly pleasant, overly just like, here's the facility, use it. And I just want to say, really check this place out, the place to heal in Sanford. The people are great, the staff is great, and they offer good services. So I just want to reiterate that.
Absolutely. And as always, folks, peace and love.
My granddaughter does this. She's like, you ain't doing it right, Grandpa. Like,
all righty. I'm going to go ahead and stop the audio recording.
All right, guys. You have a good day.
You too, Trev.